Very good evening to all of you. On behalf of Relicis Medical Device Limited, I welcome you all today in this evening. And a heartful thanks to all our attendees as well as faculty for their busy, taking out their valuable time from their busy schedule. So before we start our today's agenda, so let me take you through the journey of Relicis. So with the inspired vision of Dr. Professor Abdul Kalam to make medical care affordable in India, the company became an independent entity under the name Relicis Medical Device Limited in 2007. The philosophy behind the project was to design, develop, manufacture, and market high-quality medical devices in cardiovascular range at most affordable price, thus helping the needy patient in India and across the globe. Backed by technocrat and medical specialists, the name Relicis emerged from reliable system which ensure performance, efficacy, and safety to the patient. The strategic path adopted by the company was to innovate the cutting-edge technology beside the scale of production to achieve product price over pricing advantage and competition. So this is a basically overview of our facility. So today we own clean and green state-of-the-art facility which built in more than 12 acres of land, 160,000 square feet of built-up area, clean room of more than 60,000 square feet, HVAC building management system, built as per US FDA norms. Entire facility is certified at ISO 13485, DSR approved R&D laboratory, and fully integrated end-to-end solution for manufacturing stent and catheter. And today we are very proud to say that we are one of the largest stent manufacturer in the world. So this is a small glance of our factory. So with the vision of expansion in 2018, Relicis has acquired Multimedics LLP as a CE mark company as a part of our expansion plan. So this is our vast product range. We do have drug-eluting stent like Premier, Prestine Plus. We do have a bare metal stent, which is Cobalt-C, balloon catheter, Pearl SCNC, angiographic diagnostic catheter, Anand, C-mark based Ensure, guiding catheter Amber, guide extension catheter, Access Guide, sizing catheter Quartz, and pulmonary artery catheter, Ripacat, transcatheter heart valve, tricuspid valve as a trick valve, aortic valve as a Vienna valve, expand, which is a expandable introducer sheath, Relica, which is a microcatheter. We do have our peripheral vascular product range, which is Coral, which is a peripheral diagnostic catheter, Advert B, it is a drug-coated PTA balloon catheter, Engross, this is a PTA balloon catheter, Engross HP, this is a high-pressure PTA balloon catheter for peripheral intervention, Perinity, this is a bare metal peripheral stent system, Peripac Ace, which is a sirolimus eluting peripheral stent system. So this is our new product range. Recently, we have introduced Matrix IVL, which is a coronary interventional lithotripsy, abdominal aortic stent graft system, Metagraft AAA, thoracic stent graft system, Metagraft TAA, cutting balloon, this is a Pearl cutting balloon, coronary DCB, which is a Pearl DCB. We are soon going to launch central venous catheter, hemodialysis catheter, covered stent, transcatheter valves, transcatheter pulmonary valve, mitral valve, endoventral valve, and CTO recanalization devices. And today we are proud to say we are present more than 60 countries across the globe. So with this, let me welcome you in today's Crack Card Quote. This is a webinar series where we are going to witness the modern PCI techniques. And this is our today's agenda. And with this, let me welcome the facilitator of the evening, none other than Dr. Sergeant Commodore Mahesh Nalin Kumar. So he is a consultant and head Department of Cardiology, Parumala Heart Institute, Kerala. So he has a 32 years of experience in armed force. He is a proctor for multiple products, including rotablation, OCT, IVAS, IVL, bundle pacing, pacemakers, and subcutaneous ICD and TAVR. And he has published more than 29 articles in national and international journals. So on behalf of Relicis, we welcome you, Dr. Mahesh Nalin Kumar, sir, and we request you now to take us this program forward. Over to you, sir. Thank you.
Thank you. So let's start the evening by introducing Dr. Praveen Chandra. I can see him intermittently traveling in his car. It's a waste of time trying to introduce Dr. Praveen Chandra, who's got a Padma Shri. He's a very renowned operator. There is nothing that he doesn't do, and the volumes and the numbers speaks for themselves. He's one of the highest and the busiest operators of India, and a great person to listen to. I admire a lot of his work. Although in the NIC only both of us are there for his presentation, but it was a fabulous presentation that showed the depth of his structural artwork. So having said that and welcoming you, Dr. Praveen Chandra, to
Thank
this
you.
thing, let us start the proceedings with the first speaker. I think that is, I just opened up. First speaker, may please come on this thing. I'll take a while opening up the whole thing.
Good evening.
Madhumita, who is the first speaker? Oh, mistake.
Sir, myself, Satyajit Samanta.
Samantha, please go ahead. Yeah.
Yeah,
So
Dr.
sorry.
Shatrajit Sawanth is our first speaker.
Good
Please
evening.
go ahead. Please go ahead.
Good
Share your
evening.
screen and
It's
do your
an honor. It's an honor to share my screen with Dr. Praveen Chandra and Dr. Mahesh Nalinsa. It was always a dream to share my screens with you. So, sir, this is a very clear-cut case, and it's a very straightforward case of LED disease, a very calcified LED disease. Madhumita, please, can you?
Yeah, sure.
Next. This is a very straightforward case, sir. 58 years hypertensive lady who presented with unstable angina, and her echo shows a good LV systolic function and concentric LVs. But ECG shows dynamic changes in the anterior lead, so we decided to go for angiography. And her coronary angiography shows mid LAD, a concentric tubular calcification. Proximal to mid LAD, there is a chunk of calcium that is visibly seen, sir. So I am very sorry I couldn't have IVERS or OCT for this patient for some financial issues for this patient, but the visible calcium, it's shown in angiographical pictures only. So initially we went forward with normal NC balloons, and next normal NC balloons, 2.5 millimeter NC balloon with a predilation, high pressure predilation, but it doesn't open up. As you can see, sir, there is a dog boning, and it is not open up in the middle. So then we go forward to 2.75 millimeter of non-compliant balloon, and we open up to 20 of ATM. But still, it is dog boning, and the mid part, which is having the most of the calcium, it is not opening. So we had a few options in that time, either cutting balloon or IVL or atherectomy. So we choose IVL for this patient. In that case, I use IVL 1:1. This is a 3 millimeter LED basically. So 3 millimeter diameter LED. So we use a 3 millimeter 3 by 15, I think 3 by 15 IVL balloon, and I inflated at 4 ATM as usual with only after the second cycle, I think. After the first cycle, it is opening up, but after the second cycle only, the balloon almost completely opened up at 6 ATM. So I used few more cycles. I think I have used 5 to 6 cycles to inflate, to break down the calcium all over the artery. And after that, it inflates so easily with 2.75 and 3 NC balloons, which was not opening up initially with only NC balloons. So that was a nice demonstration how the calcium breaks down with with IVL. This is my very initial experience with releases IVL. Basically, I have done other companies IVL, but releases IVL, this was my initial experiments. So after that, we straightforward go to the stenting, and I think it's a 3 millimeter LED stenting, including the ostium, and 3.50 millimeter of NC. to post-dilate the stent. I used it, and it was a nice flow, nice symmetry flow with excellent opening up of all stars on all the things. My initial IVL use IVL with releases, but it was good and it was very easy. I think it's very easy and it was very effective. I don't think sirs need any conclusive comments from my side.
Thank you. Thank you.
They are our
Dr.
mentors
Praveen,
and they are our
your
experts
comments.
basically.
Let's listen to Dr. Praveen Chandra. Then.
So I think it's a very nice case. Yeah, I can give certainly comments on this case that using one of the devices was important, and you choosing IVL was absolutely appropriate at that stage, because once you are through with the initial balloon dilatation, then using a 1.5 bar or something like that may not be a great idea. And this was a 3 millimeter, is it?
Right,
3 millimeter.
3 millimeter.
Yeah, 3 millimeter. And then you went to multiple dilatations. Okay. And there were overlapping inflations, right? So, the interesting thing is that, was it only at one side that it was not giving up, or you did the entire length?
Pardon me, sir?
Did you do the entire length of that lesion?
Yeah,
with
I do the entire length of the stenosis, sir.
Right, very good. So I think, and then, going up to 6 atmospheres is also reasonable to do that. And most of the balloons actually stand 6 atmospheres. Sometimes they can even go higher, but definitely start with 4 and go up to 6 many times. And also after that, you could, track the stent well. There was no problem. What was the length of the stent?
The stent was a 3 into 28 millimeter size.
328. Nice.
Yeah. And
nice. So I think, although it was a straight and simple case, but definitely these cases are important to, be done initially so that, you gain more confidence, more experience. And then, of course, things become much, much more predictable.
So with IVL, the handling of calcium is very easy. It's very easier to even
absolutely.
newcomers. Yeah,
that's right. Yeah. Okay, Dr. Mahesh.
What are your comments on nailing the ostium? Nailing the ostium. What is your take on that?
Yeah, I completely agree with, because I can tell you, this is some very interesting findings. So we did a, analysis of our patients. About 927 patients were analyzed where drug-eluting balloons were done in the proximal or the mid part of the lesions. And 35% patients, the stent had to be put up to the ostium. So ostium is, going up to the ostium is not a bad idea. It's a very good idea. If you do not have IVUS, because this was all IVUS guided or OCT guided. But if he was not doing it, putting it up to the ostium was absolutely fine. It was okay. I think I agree with that, and it's a good concept. Yeah.
Yeah, I also agree with that, but it's preferably done with an imaging so that you don't.
Absolutely, sir. Absolutely, sir.
Yeah.
That's only the catch in that. That's all.
Absolutely.
So I will introduce the next speaker. That's me. So I'm going to speak. This is my first experience with this particular Matrix IVL. So this is my patient. She is a 62-year-old lady. I didn't choose a difficult case as my first case because it had to be done properly. Otherwise, it's a new device I'm not familiar with. So this is the first we did in a my preferred imaging is OCT, specifically so in the right coronary. This is the OCT image which shows as we progress, you can see this round orange thing coming up, showing practically 360 degrees of calcium. You can see that the calcium is very thick. It is not continuous. It is broken in between. And then there is another patch of practically 360 degrees of calcium as ascertained by the circle that comes around the OCT. So we got the vessel dimensions to be 3.37 plus and 2.0 the diameter. EEL was not seen in most of the places, so that thing was not. Wherever EL was seen, it was almost a 4 millimeter vessel. Okay, so we have got the dimensions of the vessel, we have got the extension of the calcium, we got the degree of calcium, and we got the thickness of the calcium. All these things in one run, easily possible with OCT. So we could get all these images, and then we went ahead with assessment of the lesion. This is how the lesion gets broken into small parts to show you. This is practically just short of 360 degrees. That's the proximal this thing. Luckily, there is no nodule to be seen. It is uniform thick calcium. You can see the calcium being around here with an area of 3.37, EEL not seen, but the lumen area of 2.07. Okay. This is the second round of calcium again. Not exactly 360 degrees, but broken in between. You can see that the calcium is very, very thick. It's more than nearly 2 millimeters thick calcium. So by any standards, it becomes a severe calcium and it requires modification, which if you don't do, you may not get very good results. Here, there are two nodules of calcium. You can see one nodule here and one nodule here. So this is, and beautifully, the third nodule here. So this is nodular form, but it is very strong, it's got a robust covering on it. So it is not a ruptured nodule. It is just a calcium nodule that's sticking out. So you got three areas. They're not continuous. There is areas of no calcium in between, and there is areas of very thick calcium nodules, and calcium thickness is very high. So this is an ideal case for IVL, because if you do otherwise, you should do orbital atherectomy, or you should your rota won't help you in these cases because you can't have a wire bias for 360 degrees. So it's going to be difficult handling this whole thing by a rota. So the choices between IVL and choices between orbital atherectomy. IVL being much easier than orbital atherectomy to handle. We went for a IVL. Now, what I want to show you is the particular the difference in this IVL thing is that it doesn't require time to recover. That is, my preparation was not the best. It had some air bubble in between, but we changed that and put a one without air bubble. I'll show you that. So this is where the thing is. There is not much of an ectopicity you couldn't find, and the movement is very easy. Expansion is very easy, and then we go ahead with it. There's no cooling off period in between, and the results and the movement of the balloon was quite easy, quite easily trackable. And this is the second area. The first area was below here. The second area that's being dealt with by the IVL balloon, and it was easily deflatable and withdrawn very easily. So in between two pulses, the timing taken is very less. I didn't have too much of ectopics coming in. That shock topics were not very many. You can see that the rhythm is totally sinus throughout this period. And this is the angio post this thing. You can see one area where it is significantly cracked. You can see this the stain there. The vessel is already with just the IVL balloon before the NC balloon itself is very well done. So I took a run of the OCT without the NC balloon just to show that this IVL has worked. So you can see this is the proximal area, a little bit of blood there. Other than that, we're coming into the areas of this thing. You can see very good areas of rupture superficially seen. See, you may not get to see all the ruptures on OCT. There may be micro fractures, but here there is micro and macro fractures. You can see them very clearly. The calcium has been modified. I will pause and show you the specific areas which has been dealt with. So here we go. This is the OCT again. This is the distal area was dilated with the balloon. This is the post NC balloon, this thing. And we took a stent. The second advantage of the OCT is it's given me the size. So I've taken a 3.5 into 33 stent distally, and I divided it into two stents because the size mismatch was significant. So here I put in a 3.5 and followed by, this is the 3.5 with a very good result, followed by, oh, I'm sorry, this is the previous, I should have shown you this previously, sequence problem. But this is just to show you the post-IVL pictures showing that there is significant rupture in the calcium. There are areas of calcium that has been shattered, visible areas. That doesn't mean that the other area has not been shattered. This is the 360 degrees with at least this area is cracked. This nodule got sorted out. I will show you after the NC has been done. And this is the run after the first the stent deployment. So as you go back, you can see that the vessel EEL is 4.3. Wherever the EL is seen, this is the proximal, this is the distal stent that I have put. I'm just getting about 85, 86, 89, 95, 87 area of 68%. Rest of the areas, okay, this is just I put in the stent. I have not done in post dilatation. This was followed by the second stent, which was put, that is 4.4 into 4 into 23. And then we went in and did a angio again. Again, we found that there are areas of under expansion which requires NC balloon post dilatation. Then this was dilated again, this time with a 4 balloon, so that we can cover the whole centered area. And with the 4 balloon, we got these results. You can see that the expansion is adequate in most of the areas. There was 2 areas where the expansion was slightly inadequate. Otherwise, more than 100% in most of the areas. There's one area here where we got about 82% result, but the area was around 6, so we left it alone. This is the area where the 3 nodules were there. I didn't want to go and do an overexpansion there with a higher pressure balloon. It can just rupture and create problems for all of us. So this is a final result. We were 3.5 stent post dilated with the 4 millimeter balloon. We got areas of excess of 8, 8.9, 8.2, 7.8. Again, you can see that the areas achieved are excellent, and that is the final result. So that is how the whole story went. The first experience with Matrix, very good results, very good expansion, and what I could find out was the shock topics were lesser, the results were very good, and the time between the shocks, and you can just straight away deflate the balloon, pull it back, inflate, and deploy again. Overall, excellent results. Thank you.
Very nice case, I must say, Dr. Mahesh. And the nodules which you showed, so tell us more about that. That at places where we have nodules which are more resistant to fracture and expansion, so did you spend more time, more pulses over there compared to the other sites where the nodules were not there? I can't hear you.
Out of the 80, 40 was spent on the areas of the nodules. Then
Right.
20 I spent in the proximal area and 10 in between. So my predominant thing was in the nodular part of it. And there is an article which we had published in JACC last year, which said the nodular calcium does get modified by the IVL. And that was the most cited article in 2025 JACC. So that is why that is so important, that the concept that the nodules do get sorted out by IVL is accepted.
Yes, absolutely. So this is the best part of the whole thing, is that IVL treats plates, IVL treats ring calcium, IVL treats thick calcium and thin, and also the nodules, both smooth and eruptive, right? So that is the best part of the whole thing.
Exactly. Anybody else got anything to say? Otherwise, we can go to Dr. Mahesh Murthy. Mahesh Murthy, are you there?
Sir, sir, good evening.
Yeah, go ahead, Satya.
Can I ask you something, sir? Sir, basically, I already know that IVL just tracks only the calcified part, not the healthy endothelium, basically. But after few cases, after 10, 12 cases, one of my cases shows a dissection. It was not a major dissection, but a dissection. So, why is dissection occurs with IVL?
Post IVL, you will be doing an NC balloon or you'll be dilating with the IVL balloon.
Okay. Yes.
That itself causes a dissection, not
Okay,
necessarily
that
that.
dissection, not
Yeah.
the shockwave.
Yeah.
Basically.
So dissection is not such a, any
It's a
bad
good thing
event
to
in
have.
this whole process. It is part of the whole, because you are still dilating a balloon, you are still creating those fractures, and there is that variability of the response of the, the calcified area and non-calcified
Mhm.
area. So that
Okay.
is why do not get scared with dissection. It's okay because you are finally going to stent it.
Right, sir. Right. Sir. Thank you.
If
But the question
maybe
asked
I'll
is,
take off at this time, and
yeah,
I wish that I would have stayed more, but definitely I will see if I can join later. But
thank
please go
you. Thank
ahead,
you for
and
being
thank you
there.
very much.
It's like a index journal. Your presence increases the importance of the talk by
No,
so
no,
many
no,
times
no, no,
more.
not at all. Yeah, but I must see your this article. Maybe you
Yeah,
can share to all of us.
I'll send you across. I'll
Yeah,
send you
yeah.
across.
Thank you,
Thank
thank
you
you.
so much.
Okay.
Thank you. So the question being asked is where to place the IVL catheter to get the best result. So you see the IVL catheter goes in like a small. You go to the IVL to the area that you have to do, and don't keep it right on top of the calcific nodule like that. First, you keep it here, expand it to 4 to 5 atmospheres, shock. Then you go on top of the nodule, expand it to 4 to 5 atmospheres, shock. Then you go down the ridge and then expand it to 4 to 5 atmospheres and shock. So advantage is if you keep it here and shock, your shock waves will not reach all the areas that it requires to reach. If you keep it here, here and shock, like a small worm going over a hill, then you will get a much better result than just keeping it here, enlarging it and shocking it, that the shock nodules will be a little away from the calcium that it is. In this way, the shock nodules will be practically on top of the calcium that you want to rupture. So don't keep it exactly on top and first do proximal to the lesion, then go distal mid to the lesion, then you go distal to the lesion. It can be done. Now, can IVL be used post-stenting? Answer is yes, but recommended not to. Why? Because what is the golden rule of a calcium lesion? You should prepare the lesion and expand an NC. Suppose you're going to put a 3 millimeter stent there, expand the 3 millimeter balloon and see it in two orthogonal views that the balloon is expanded well. So if you do that, then when you put in your stent, you will automatically have a very good expansion. And that is the best way to do it. Now, by chance, you have not done that and you're stuck with a situation where there is calcium and you have already deployed the stent, then you should go ahead and put in an IVL inside the calcium and inside the stent, and you can deploy, you can deliver shocks from the IVL. It doesn't usually damage the stent. It helps in stent expansion. What should be the size guidance? Ideally 1:1 for the IVL balloon. Ideally 1:1 because you're only going to 6 atmospheres. You're not going to 15, 20 atmospheres. So try and get 1:1 if it's possible. Yeah, can we go to the next speaker? That is Dr. Mahesh again. Yeah.
Yeah.
Please go ahead.
Yeah. Good evening, sir.
Good evening.
Let's talk.
So Dr. Mahesh, in the below, there is a share button. You just need to share the screen. Yeah, thank you.
Perfect. Now go on screen.
Slides not able to.
So you go down to your this thing and see if you have a thing called.
Sir, you just need to go to your particular slide.
Yeah, I'm not able to share that. Slides are in desktop actually.
You can minimize this, sir. In the you just minimize it. Yeah.
Yeah, now. Yeah. Is that okay?
It's not opened.
Yeah. Share. Share. Is it okay?
Yeah, we are on. Now go to full screen.
Yeah. No.
Perfect.
Okay. Share.
You are doing well so far. Now suddenly you take it off. Go on, share again, please. Yeah.
Yeah. Now we can move there. Yeah, sorry.
Yeah.
Good evening, all. I'm Dr. Mahesh Murthy. I'm practicing at Medical College and Hospital at Shumaga, Karnataka. I'm associate professor. So I'll be presenting a case which is interesting, like 66-year-old male presented with unstable angina with adequate LV function of EF 60%, and he's a known case of hypertension. So when we did an angiogram, which was showing left side shoot, right radial approach. Here you can see LAD was proximal some 30 to 40% lesion. L6 was showing relatively like proximal 30 to 40% lesion, and the side branch, that is OM, was around 2.5 mm, 2 to 2.5 mm with significant lesion. And for this patient, culprit lesion was right coronary artery. See, this was a right coronary artery. See, primarily you have to go for the stenting of the right coronary artery that we did with 2 DES. Okay. But CAG revealed that we did the stenting for a RCA. But the problem was with the OM stenting. Like this OM was in the OM ostium, which was starting from the L6. Like lesion was starting from the L6. So for this, stenting was not a good option. So we wanted to revascularize since it was a significant lesion. So what I did was I thought of going with the DEP, that is DCB, duct coated balloon. So left main and all other diseases were acceptable. So planned for lesion preparation with plain balloon followed by drug coated balloon. So after pre-dilatation with 2.5 into 12 semi-compliant only, I deployed DEB in this position, that is 2.75 into 28 in the OM. I dilated it for 6 atmosphere for 60 seconds. This was the final result. It was achieved with no residual, mild residual stenosis, and no dissection. So finally, the result was well achieved. Like TME3 flow was noted with no complications, no dissection, and stent-free result was seen in OM1. This was a very simple case. I just wanted to highlight the thing is like many of the side branches, we cannot use stent because when we place the stent at the ostium of the side branch, we compromise the main vessel. So which was avoided because of this drug coated balloon with comparable results, and with like stenosis was less than 30% when compared to like normal lumen. Thank you.
Yeah, very good approach, Dr. Mahesh. And I think the two things I would like to suggest is that if you had an imaging, the things would have been more evident. That's all. Nothing great. Do you think the circ was diseased, and do you needed to look at the circ also, or you can leave the circ alone?
Yeah, since it was an inferior like kind of thing, it was RCA was the culprit, but L6 was looking significant. So I thought like complete revascularization would be helpful for that patient.
No, OMS I accepted. Do you think the circumflex was diseased, the main circ?
Circumflex was mildly diseased, sir.
So
Proximal.
after the drug coated balloon, did you have any plaque shift into the circ?
No plaque shift, sir.
So these are things that you should be looking for. Otherwise, I think you have proved your point that this is the way forward, specifically in cases where you are you are dealing with a not so important, at the same time a vessel which can be very irritating if we miss it or do something bad with it. Thank you.
Sir.
Very, very good case. Now, the question is from Madhumita. It says, currently sirolimus and paclitaxel both is available. You see, most of the studies are supporting paclitaxel, but there are specific indications where sirolimus may be used. Small vessels, long lesions, diabetics, you may use as when you have an ISR and when you have proximal lesions, when you have acute lesions, people prefer paclitaxel over sirolimus. And there has been a few studies, surprisingly few studies, which showed that in very bad ISR, when you treated the patient initially with the paclitaxel balloon and 2 minutes later reinforced it with a sirolimus balloon, that is two drug-eluting balloons in the same lesion, the results are being studied. So that's a new concept that's coming up. So predominantly, when in doubt, use paclitaxel. When you have long lesions, small vessels, then you may consider a sirolimus as a lesion. So as of now, most of the studies en masse support paclitaxel. But sirolimus is also equally effective, but you should choose a case properly. What is your guidance about vessel preparation before DCB? Don't create too bad dissections. You should create dissections. There has to be a few dissections. So ideal, my protocol would be an NC 1:1, then do a cutting balloon with a slightly smaller size cutting balloon. And then like for a 3 millimeter vessel, I would use a 2.75 cutting balloon, create cracks, and then go ahead and do the DCB. So this is the DCB, preferably good preparation, adequate dissections in the vessel. That will help the DCB the drug to be absorbed faster and deeper. Don't create more than type 2 dissection, then which case we'll end up stenting. So after the dissection has been found, if you are sure that this is going to be only a minor dissection, go ahead and do a DCB. If you're not confident, you should go ahead and do a stent.
One question, sir. Like this for dilatation, pre-dilatation, no?
Yeah.
Like simple lesions, whether we have to go for NC in all the conditions or even semi-compliant balloon is also fine. 1:1.
Pre-dilatation, NC is preferred, point number one.
Yeah.
Point
Yes.
number two, in pre-dilatation, if you're planning for a DCB, a scoring balloon or a cutting balloon is preferred. That will give you a better controlled dissection. The terminology is controlled dissection. NC there's like a grenade thrown into a vessel. It'll just shatter the vessel all over, while these cutting balloons give you a controlled dissection that is going to be good. For next question is DAPT recommendation for DCP. I use DAPT for a month. After that, I switch over to clopidogrel is my usual thing, or is my usual thing for the rest of the life. So the biggest advantage is DAPT for 90 days, 30 days definitely. After that, you may discontinue. That's the biggest advantage of using a drug-coated balloon. Okay, let's go to Dr. Avik for his presentation, then we'll continue with the discussions. Dr. Avik, all yours.
Yes, sir. Thank you, sir. I hope I'm audible.
You have to go to the share screen. Yeah, perfect. You're already started. Yeah, now go on to slideshow.
Yeah, good evening, sir.
Slideshow.
Yes, sir. It's already there. I've already started it. It's visible, sir.
We have seen the full slide with the left side slides being seen. If you go to slideshow from current slide, it will be better. Upper from current slide. Just press that left on top or left on top. From current slide लिखा है ना?
Okay.
Yeah. Meeting लाना है. एप्पो लिखा.
So is it visible now?
We can see. Yeah, perfect. Go ahead.
Yeah. So thank you. Thank you, sir, for giving me this opportunity to present. So this case is basically to elaborate the use of cutting balloon over and above some other calcium modification which is necessary in certain cases. So this patient basically was a 65-year-old female diabetic, had presented with a refractory class 3 angina despite medical management of high dose of nitrates, nicotindale as well as ranolazine. The LV function was normal. So the CT angio was done from outside, which showed a severe stenosis of the left main ostium, and the left main was pretty calcified. The calcium score was about 127. There was a chunk of calcium in the proximal LAD, and there was a significant amount of calcium as per the CT angio on the left main ostium. So the echo showed good LV function. So this was the angio. So we had the angio was also done from outside, which showed ostial left main. So the patient had presented to us for plastic. So we went ahead with the PTCA by the right femoral approach. So what we had planned is we put a temporary pacemaker as a backup from the right femoral vein. From the right femoral artery, we took a 7 French JL 3.5 guide cath. We had a non-selective shot which showed this. After that, we had planned for doing a rotational atherectomy initially. So we used a stiff extra support rota wire. We parked it in the distal along by using a microcatheter. Then we did a rotational atherectomy with a 1.75 mm bar at 1.65 lakh RPM. So this was a rota run that we had taken. It was fairly easily negotiable left main ostium. Rather, the more difficult part was the proximal LAD. So after this, this was the angiogram after the rotational atherectomy, so which showed significant stenosis still there in the left main ostium. So I was not sure about the amount of lumen gain or the modification that we could achieve, because unfortunately, due to financial constraints, we could not go ahead with a intravascular imaging. IVAS should have been done in this patient, but we could not. So I was not pretty much sure about the calcium modification that was done. So we had thought of proceeding with an additional cutting balloon ablation of the ostium as well. So we took a 3.5 mm, 3.5 mm cutting balloon. Dilatation was done at a high pressure at the left main ostium. This was the left main ostium dilatation. After that, there was an adequate lumen gain, the angiogram showed. So we took 3.5 into 28 mm drug-eluting stent was taken from the left main ostium. After that, we dilated it, and then we did a pot of the left main with a 4.5 mm balloon. And this was the final result after the PTCA procedure. So this was a fairly good result. We did not recross into the circumflex because the circumflex did not show any compromise in the circumflex ostium. There was no plaque shift. It was a flowing vessel. So we did not do anything further. It was a TME3 flow. The patient was hemodynamically stable. So we completed the procedure by doing this. So the take-home message is synergistic plaque modification is often necessary in certain cases, especially in this case. It basically helps us in adequate, adequate lumen gain. The cutting balloon often minimizes the perforation and dissection. It has a controlled radial force. It helps in enabling an optimal stent expansion. And whenever we are dealing with a calcified stenosis, we need to plan the case adequately beforehand. We need to have all the armamentarium in our hands adequately. And a single calcium modification might not be enough always in all the patients. So we need to have some backup support. In this patient, the cutting balloon gave us a very good help, the Pearl cutting balloon. Thank you, sir.
Great case, Avik. Considering the fact that you have no gray hair on your head, that's a fabulous case
Thank you, sir.
for your this thing. Excellently well done. I wish there was just a little bit of IVUS. It would have given us taken the case to a different level. Which cutting balloon and why?
So we use the Pearl cutting balloon. Why? So because it was available at
there is scoring balloon. There's something called aperta. There is something called a cutting balloon with this.
exactly.
So which, where, when, why?
So, but in this patient, because it was an osteal disease, osteal left main, so what we felt is there was already calcium. Again, IVUS was not there, so I was not sure much about the, the calcium modification that I could do by the rotational atherectomy that I had done. I had taken a fairly large size burr, 1.75 mm burr was taken, but still I was not pretty much sure about that. So in that situation, sir, when there is a calcified osteal stenosis, probably a cutting balloon is a bit better over the scoring balloon for the cutting of the calcium probably. So
Totally
I think probably will be able to
totally
help.
agree with you. I just want to know your thought process and why. I agree with you 100% on this topic. Any questions from anybody else or any comments from any of the participants? Dr. Mahesh, Dr. Satarjit, if you're still there. Madhumita, any comment, any questions to be answered? Any further questions? So do you have IVUS in your place, Avik?
Yeah, yes, sir. Yes, sir.
Get used to doing it. It takes a few minutes extra, but makes the case, you
exactly.
don't have, you're in India, man. You don't have to use a new catheter for everybody. Just quietly sneak in, do a G catheter, do a small run. It'll give you a phenomenal different view. You have in one view seen the circumflex ostium and decided it is good. Probably if you had an IVUS, you would have been more comfortable. That is the.
So actually, sir, what actually had happened is when we had initially planned the patient, so the budget actually was given including an IVUS. At that point of time, cutting balloon was not done. So on spot after the rotational atherectomy, we actually decided to go ahead.
You don't reuse. You don't reuse.
Yes, sir. Reuse we use, but again, I was a bit skeptical about the left main ostium. That is great.
Just do it. Just do it.
Yes,
where to use cutting balloon and where to use scoring balloon? That is a question you have just answered. Where there is calcium, where there is an osteal lesion, preferably going for a cutting balloon. Otherwise, you can do a scoring balloon before aperta being an there's a balloon in between, neither cutting nor scoring. So that also again cutting balloon to be used in ostium and calcium. Very good. What are the indications for cutting balloon? The indications are where you have a lesion which is calcified or extremely fibrotic, where the NC balloon doesn't give you an adequate result. A very good idea is to do a cutting balloon specifically in the ostiums because it gives you a very controlled dissection, and specifically in cases where you're planning to do a DCB, it's very good to use a cutting balloon.
Exactly.
Any other questions from anybody? Madhumita, the boys, the court is back with you. So she's hiding.
Sir, this is the last question we received, so I just.
What is your thought on stentless PCI is the way forward? 110%. I just met a few operators from the UK who are doing even left main bifurcation without stents. I don't have that, that much of guts, but any vessel that is less than 3 millimeter, any bifurcation that is less than this thing, and specifically circumflex ostium, I now just do a cutting balloon and followed by a dark coated balloon. It's working wonders because because how we put it as it is almost maybe a year since I did a proper DK crushed, because I'm getting away with cutting the ostium of the circumflex and putting a drug coated balloon. So drug coated balloons is future, but it'll take a little more while before we can actually establish and give you studies to prove that this is actually better. Yeah, all yours, Madhumita.
So thank you. First of all, thank you very much, sir. On behalf of Relisys Medical Device, I want to extend our thanks, and we are very, very grateful to all our speakers, our audience, especially today's facilitator of the evening, Dr. Mahesh Nalin Kumar, the chairperson of the evening, Dr. Praveen Chandra, and all our speaker, Dr. Shatrajit, Dr. Mahesh Murthy, Dr. Ravi.
You have chosen very good guys, huh? Just stick to them. Avik and Mahesh are surprisingly good. So when you have more opportunities, make sure that these guys are there. That's how we promote good guys.
Sure, sir.
Thank you
So much. And sir, we hope this webinar could able to bring an insightful and meaningful discussion on the table. And this webinar series will keep on continue. So our next webinar series will be in next month, and we will announce the date very shortly. And we are very happy to announce, sir, at this point of time, we have more than 375 audience live from Pan India. Thank you, sir. So either they are in Cath Lab or either they're from individual joinees. So put together, we are having 375 audience as of now with us. So we are very grateful to all our audience for taking out their time and watching us live. And with this, let me conclude the session here. And once again, thank you very much. Wish you a good night. And
thank you, guys. Good night.
Thank you.
Good night, sir. Thank you, sir. Thank you. Yeah.